Imagine flipping through photos on your phone, looking at a picture you snapped of a toddler. The camera flash went off, so you expect to see that familiar, annoying red eye effect. But as you zoom in, you notice something strange. One pupil has that typical red reflex, but the other one is glowing an unnatural, bright white. This pale reflection is called leukocoria. It is the primary warning sign of a rare, aggressive childhood cancer. This is retinoblastoma. It is the most common primary tumor that originates inside the eye during childhood. It appears in roughly 1 out of every 20,000 to 30,000 live births, and the average age of onset is incredibly early, typically between 2 and 3 years old. A mutation in the developing cells of the eye eventually forms a smooth white or pink mass, growing directly out of the retina. If left unchecked, the tumor can metastasize via the bloodstream. A localized visual anomaly rapidly escalates into a direct threat to the child's survival. To understand how this cancer spreads, we have to travel past that white reflection and down into the microscopic landscape of the retina. The tumor originates in retinal progenitor cells, the immature cells meant to form the light-sensing tissue of the eye. From there, the tumor takes one of 2 structural paths. The first is called endophytic growth, where the tumor grows inward, spilling directly into the clear vitreous gel that fills the center of the eye. The second path is axophytic growth. Instead of growing into the center of the eye, the mass burrows backward, forcing its way into the subretinal space and peeling the retina away from the underlying tissue. This outward expansion is particularly dangerous. By breaking through the back layers of the eye, the tumor enters the optic nerve corridor, creating a physical bridge into the central nervous system and, eventually, the brain. Knowing whether that mass is pushing forward into the gel or backward into the nerve tells doctors exactly how the cancer is moving and how aggressively they need to act to protect the brain. While retinoblastoma is the most frequent internal eye tumor in children, the eye and its surrounding structures can host entirely different types of dangerous growths. Take rhabdomyosarcoma. This is the most common primary tumor of the orbit, the bony cavity containing the eye. It reveals itself through a severe bulging of the eye called proptosis, often accompanied by a squint. This scan shows why it is so lethal. Unlike an infection like orbital cellulitis, which is highly painful, this tumor is painless. It grows silently in the socket, with a high risk of spreading directly from the orbit into the surrounding skull bones. Other rare threats include angiomatosis retinae, which creates red nodules and swollen, bulb-like blood vessels, or primary intraocular lymphomas, which scatter malignant cells directly into the vitreous fluid. Yet, not every mass is a cancer. Some children develop choroidal osteomas, benign, bone-like tumors that sit near the optic disc and give off a golden-orange glow. Because malignant tumors share physical traits with completely harmless growths, clinical guesswork is dangerous. Precise imaging and anatomical mapping are the only ways to separate a benign anomaly from a fatal misdiagnosis. Once the exact nature of a tumor is confirmed, the medical focus shifts towards neutralizing the threat. When lesions are caught at their absolute smallest, doctors can deploy highly targeted weapons. This includes using laser photocoagulation to burn the tumor cells away, or cryotherapy, rapidly icing over the abnormal cells to destroy the malignant tissue. If the tumor has grown large or seeded itself further into the eye, the interventions have to escalate. Patients require localized radiotherapy fields, systemic chemotherapy, or in the most severe cases, enucleation, the complete surgical removal of the eye to stop the cancer's advance. The difference between a targeted freeze and a total removal comes down to timing. That is why recognizing a sudden, persistent squint, known as strabismus, or noticing that white glow in a photograph is so crucial. If those signs appear, the clinical protocol is absolute. A practitioner must dilate the pupil, examine the fundus scarily, and immediately refer the child to an ophthalmic oncologist. Catching that pale reflection early gives doctors the exact window of time they need to act. Treating early warning signs with immediate urgency is the definitive factor in saving a child's life.